Thank you again. I will now show some of my case experience in the multidisciplinary tumor board in the neuroendocrine tumor setting. Again, the disclosures and role of nuclear medicine physician. So give you an example of, I have two roles. I'm still in the faculty at Mount Sinai, but I also have established a new Theranostics Center in Princeton, New Jersey, and now we are scaling out multiple centers all over the US as part of United Theranostics. So I'll share some of my experience from that new venture as well. It's a major healthcare system in New York with 8 major hospitals, more than 7,400 physicians, and one of the largest training program in US. And this is what we established over the last 3 years with a very busy Theranostics Center. These are the 2 dedicated nurses that are only practicing Theranostics full-time. And just before I left as the chief of service, I ended up recruiting 1 more nurse, again full-time, into the workforce. These are some of the centers set up where we have radiation safety officer working with us in setting up the room beforehand, and then actively involved in monitoring the patient throughout the process. And then the new center that I was referring to, this is in Princeton, just opened up about 6 months ago with multiple infusion rooms, dedicated hot lab, and then individual rooms that accommodate the ability to deliver amino acids as well as the radiopharmaceuticals with sufficient room around for the patient to monitor. And then at Mount Sinai, Edward Wolin, who's a world-famous neuroendocrine physician, under his leadership, there's a multidisciplinary team that meets every Thursday evening to discuss these cases. And several nuclear medicine attendings and residents are in attendance. Nuclear medicine physician reviews the imaging, staging, and extent of the disease, and surgical resectability are discussed. In the recurrence setting, the role of PRRT and the level of DOTA rate expression are reviewed. And then in the setting of metastatic disease and unknown primary, we look for the imaging indicators, and I have a case to share with you. So let's dive right into it. This is one of the most complex patients that we have managed, and happy to report that after several years and having 2 cancers, imagine this, our role in this particular setting has been in the same patient having both neuroendocrine tumor as well as metastatic prostate carcinoma. And here are the details of the individual disease process going on. For the prostate cancer, was initially treated with Lupron, and for history of pancreatic neuroendocrine tumor, had the surgical resection first in 2017. So both were diagnosed within a year of each other. Then in 2019, the MRI shows multiple metastases, which is where we stepped in. And you can see the individual scan. So on the left hand of your screen is metastatic prostate carcinoma with multiple sites of metastatic disease. And on the right is the gallium dotatate scan showing, again, multiple metastatic lesions, but particularly you can see very clearly that the liver is mostly involved with metastatic neuroendocrine, whereas bones are involved with metastatic prostate cancer. So when we were discussing this treatment option, one of the things was very clear is that while the patient is continuing all the other treatments, is that in order for us to decide which treatment to give, we saw that there were considerably more metastatic lesions from prostate cancer, and so we decided to approach it with systemic administration of lutetium PSMA. And then what we decided was for the dotatate expressing liver lesions, we went with I recommended that we go with the bland embolization of liver lesions. So patient had 2 settings, one for the right lobe, one for the left lobe, and then we followed the patient up. And quite rewarding experience. You can see that when we look at the metastatic lesions in the prostate, before we ended up treating, both of them were showing progression. So the liver lesions are going up on the neuroendocrine side. The metastatic prostate cancer lesions are going up on the PSMA side. And we reviewed this in the tumor board and showed that if you target these lesions with liver-directed therapy, and then these lesions, which are in the skeleton, with the systemic therapy, with lutetium-177 PSMA, that would be the best approach. That's what happened with the patient. Post-treatment scans, again, showing the expression of PSMA on post-treatment scans. And then PSA started to drop on the patient. And you can see that after the 3 weeks after second cycle, there's a drop in PSA level. And patient's hematologic profile was acceptable. And then we started doing the tumor volume analysis. And we showed that after 3 cycles, on the post-treatment scan, there was a significant treatment response. And you can see the volumetric analysis here demonstrating total lesion assessment as a 63% drop after 8 months. So current status, it has been several years with 2 metastatic cancers in the same patient. He's still symptom-free and continues to come for regular evaluation on a 6-month basis. So very happy outcome of the patient. The other one is an unknown primary. This is a surgeon himself and came in with abdominal pain, biopsy of the liver lesion. It was this particular lesion that was biopsied and confirmed the presence of a neuroendocrine tumor. But the patient had unknown primary, and what we ended up doing, this was a copper-64 dotatate scan, and we found this lesion in the small bowel with no correlate on the CT. Again, as I mentioned, we discussed the cases on Thursday. The patient was scheduled for surgery on Friday. And I mentioned to the surgeon who was in the tumor board, I said, you'll probably have to palpate every single component of the distal ileum, starting from ileocecal region, to make sure you don't miss the primary. And next morning, he operates. As soon as he walks out of the OR, he calls me, and he says, Munir, you won't believe when ultimately, I found some little nodularity, and I just resected that part, and it turned out to be a 1 millimeter primary of neuroendocrine tumor. So you can see how, with the signal amplification that we are able to accomplish, we are now challenging the paradigm of what's called system or spatial resolution of CT, where you would never look at a 1 millimeter primary in a small bowel. It's impossible to pick that up on a CT scan. But because of that molecular expression, we were able to pick that up. And it's increasingly being recognized that we are now getting into a domain challenging the anatomic resolution limits. I'll end with this case. Unfortunately, this was not as good of an outcome as the first 2 cases. And the reason being that this patient has metastatic neuroendocrine tumor, but we had indicators that patient was not doing very well. And we wanted to make sure, was there even a reason to treat with lutetium dotatate? And it turns out, as you can see, Dr. Akram showed some combinations of FDG and targeted scans. This is one such example where, unfortunately, the targeted scan shows only minimal disease in the liver, but the FDG shows extensive liver and peritoneal metastases. But the advantage of this approach is that at least when you know the patient is not going to benefit, you stop that treatment and go for other approaches, including systemic chemotherapy. So not every single case will be a winner when it comes to targeted radiopharmaceutical therapy, but the advantage to us is that our imaging is allowing us to pick that non-responder earlier and be very selective in deciding which patient should continue the treatment. So with that, I'll end my presentation, again showing you the MIP images, extensive metastatic disease, not expressing the somatostatin receptors, only one in the left lobe of the liver has the major uptake.